patient from Vyagi care can be treated like this. The issue of stigma and discrimination comes here also, and the dirty looks that are given when they know that a person is HIV positive or something. These things, we have seen patients who say that outside when they go, they are being discriminated against.
I think that is why it's important to keep confidentiality, and sometimes it's not possible to keep absolute confidentiality because of the nature of the problem. If you're taking, as you, from what you said, like you had to say from where you are, or somebody is, there's a cross-referral. We'll come to cross-referral issues later, because where you're asking for a medical opinion, certain information would have to be divulged to, ensure adequate medical care. So we'll sort of come to that point later. But I think what you've brought up is a very important point. But the other flip side of confidentiality, which I'll discuss in the next slide, is that sometimes patients refuse to give you permission to talk to the spouse. And how should you handle that? We'll come to that in a minute. Ma'am?
And when we are involved in studies related to behavioral areas, the persons who are high-risk populations like sex workers, MSM, drug users, not disclosing about their sexual identity and also behavior. That is another area where we need to take importance for the confidentiality.
Yeah. If you're going to do a public health kind of activity or surveys, you have to assure confidentiality, because otherwise you'll not get the information you're looking for. So with HIV/AIDS, the American Psychiatric Association, they basically said that doctors have a duty to warn partners, provided the patient has been encouraged to provide the warning himself, has failed to do so, and is informed what information will be shared and with whom. Now, the reason the American Psychiatric Association took this stand is that they found that up to 33% of HIV patients, HIV positive patients, because they are otherwise physically healthy, they sometimes manifest subtle signs of dementia, depression. So often the psychiatrist is the first medical doctor to see them and ask for the HIV test. So that is why the American Psychiatric Association has been very actively involved. And there, the practical issue is that where a patient is sexually active and refusing to tell his partner, what is the duty or the obligation of the doctor? Now, I feel all this is fine on paper, but when you are to deal with a practical situation where a patient refuses to tell you, to give you permission to talk to the partner, though this sounds common sense, it takes a lot of time, but is really to ask the patient, why is it that you don't want me to tell your partner? Now, I feel in India, one issue is that a lot of our partners, a lot of our patients are married, and at least we see them at that time. I mean, by the time they come to us, they're married. Sometimes they've been positive before marriage. Sometimes they've picked up the infection after marriage. And they're very categorical about saying that you can test my wife, but don't tell her it's for HIV. You can test my child, but don't tell my wife it's for HIV. And I remember one referral I got, which was very, very difficult to handle, because the patient was referred saying that he was HIV positive. And when the pre-test counseling was done, he had said, you can tell my wife. The moment the report had come, he had flatly refused to allow the doctor to speak to the wife. Luckily, the patient was admitted. So when I went and saw him, he was quite depressed, but not clinically depressed enough for me to feel that it was affecting his judgment. And his basic point was simple. He said, you're asking me to tell my wife this. He said that, how can I tell her that I'm going to be dying? How can I tell her that I could have infected her and she could be dying? And the worst thing to tell her is that, how can I confess that I've been unfaithful to her? And when you listen to this, a part of you feels, gosh, yes, how can I ask him to, put his head on a railway track and wait for the, train to hit him? So I had to have several sessions with him with the help of my psychiatric social worker, and we had to address each issue one by one. And the first issue, we had to say, yes, it is difficult to tell your wife you're going to die, but the reality is that you have AIDS, your physical health is in quite a bad shape. This was much before the ART was freely available, and it was extremely expensive. He wouldn't have afforded it also. We said, yes, things are bad, but your wife needs to know that. You've got 2 small children. You may want to make plans for their future. You may want to sort out your financial issues. You may want to keep FDs. Whatever you want to do, your wife needs to know that. Yes, she will be upset, but we will help you deal with that. The second point, we said that, yes, you may have infected her, but surely she has a right to know. And he was very categorical, yes, you test her, but don't tell her. So we had to have explain to him why we couldn't test her without doing a proper pre-test counseling. And yes, if she's positive, it is going to be devastating for everybody, but we have to deal with that. And the third point, his thing was, how can I tell her that I've been unfaithful? That I said, I'm not going to lie to her, but I can broadly tell her the various routes by which HIV is transmitted. And he says, yes, you tell her I got it with, he also had tuberculosis and he had seen many doctors and got injections. He said, you please tell her I got it with IM injections. So I said, I cannot lie, but I can say that these are the various routes and it's up to you. If you want to tell her that, that's up to you. Because I didn't feel there's a reason for me to tell him how he got the infection. That was really not necessary. And finally allowed us to tell the wife. She was understandably upset that he had this and he hadn't told her. And fortunately, when we did the HIV test, she was negative, which was a wonderful thing. And the third point, she said she was well aware of his multiple sexual liaisons. She said that I knew that was going on, but after her second pregnancy, it had stopped. So she said that is in the past, I'm not bothered about it now. So it turned out to be a non-issue. Okay, so but the crucial thing is you need time. And what I've now realized when I do pre-test counseling, especially as an outpatient, I tell the patient the pre-test counseling, who do you authorize me to tell if you're positive? They say so and so. I say you come with so and so, only then will I do the post-test counseling. And I make sure that they're outside and they're waiting, because I've had too many times, otherwise a patient changes their mind. Okay, that they say no, you can tell so and so, then they say no. And especially as an outpatient, it's very difficult to give the patient and the wife the time that they need to handle this sensitive issue. The other issues of confidentiality in special situations is the other issues with genetic disorders, like Huntington's disease, where if a patient is a carrier and he refuses to allow you to tell the wife or the fiancé because he's worried that the wife may refuse to have children, what the general advice is that if the patient is not suffering from a mental illness which is affecting his capacity, as a doctor, your duty is to tell the patient why he should tell his wife. You're not a moral policeman to go and call the wife and tell him that. So what I would do is that I would record in the file that I have advised the patient to tell his wife or tell his fiancé. And if they choose to do it or not do it, that is their issue, because it's totally inappropriate for me to pick up the phone and try and call them or things like that. In fact, this is an issue not with genetic disorders so much as increasingly we are seeing now with patients with major mental illness like bipolar disorder and schizophrenia doing very well. In fact, probably one of the good things of the tech boom in Bangalore is that a lot of our patients are rehabilitated very well. They work in quite a few of the big companies and they're doing pretty well. But what happens is that if they have the illness before marriage, quite often the family doesn't want the fiancé to be told about this illness. And I find that it is quite important to spend adequate time with the patient to explain why it is important to explain about the illness and medication. And I find that a lot of my male patients are perfectly fine about telling their fiancés. They do that and there's no problem. With the girls who have problems, the results are a bit mixed. Somehow the men who they're going to marry may not be that supportive. Some marriages have broken up. Some engagements have broken up, but we do see increasingly a lot of young men who are perfectly comfortable to marry women with mental illness so long as it's disclosed and the patient is undergoing therapy and are stable. In fact, we do see some of them coming to see us as an outpatient clinic wanting to know the genetic risks, and that is fine because the patient has given consent, has brought the fiancé to see you, and they want to understand everything before marriage, so that's no problem at all. The other issue is confidentiality when dealing with children. Now, this is a very, very difficult area, and sometimes I'm glad I'm an adult psychiatrist and not a child psychiatrist. And the practical problem with children is that what is said is that very small children really don't have a sense of autonomy. Developmentally, autonomy develops in children gradually from the age of 12 to 15. And they've noticed that very small children, if you promise them confidentiality, they actually get more anxious. So, so you have to work with what is needed, what has to be told, and you can be quite directive about that. We don't have to be blind about confidentiality. And with adolescents, it's a very, very tricky area. And what is advised is that when you get information about certain risk behavior, like smoking or alcohol, you have to use your judgment. If you blindly tell the parents the adolescent is not going to come back to see you. If you, and one example that's given is that if you, through your sessions with the child, you find out the child is occasionally smoking some grass, you may feel I'm not going to tell the parents that. But if the child is using IV drugs, you may feel, definitely I'm going to tell parents that, because there is a boundary, but I'll come to how you breach confidentiality. There's a certain way you could do it without jeopardizing your doctor-patient relationship. The other huge problem is with cross-consultation. I think you had mentioned that when there's a reference, you can do everything to maintain confidentiality. When you refer across to somebody else, they may not maintain confidentiality. So it's very important to balance what information is needed by the doctor who's going to treat the patient. So if you're a psychiatrist and you've referred somebody to the gastroenterologist for hematemesis, and the patient says, please don't tell the doctor that I'm an alcoholic, you'll have to convince the patient that if you don't give that information to the gastroenterologist, he's not going to have adequate information. But suppose he says, don't tell the gastroenterologist that I'm homosexual, that may be reasonable, because that has no bearing to what treatment the patient is going to receive. What I tend to do, again, in St. John's, because we work it's a general hospital, so the system is that patients come for their psychiatry referral in an OPD card, where it's across all departments. So you can go to ENT with a ear infection, and they feel that you're depressed, they send you to psychiatry. What you write is not absolutely confidential, because the next day if he has a rash because of your drug, he goes with that to the dermatologist. So you have to balance what information you write, because I have to put enough information so that if the patient comes next time to see me, I know what I've done. Or if I'm on leave and my colleague is seeing, he knows or she knows what's going on. So what I've devised is, what we do is that we write the relevant information which is not going to cause a problem. And if you pick up some sensitive issues like child sexual abuse or a family history or something that is relevant, you can say other relevant issues discussed. So I put that because that is for me a code that there is some other information there. And if some other psychiatrist is going to see the patient a month from now, they will know, yes, childhood events important. There may be something there, and they would ask that. So you need to be careful about what information is divulged there. The other issue is confidentiality in writing and speaking. I suppose the person who's talked about research, I don't know whether they've talked about this, is that case reports. It is very important that the information is sanitized so that you can't identify the patient from the demographic details that you've put. And what a lot of journals, international journals request you is to get a written consent by the patient who has seen the case report that you've written. Okay, he needn't see the discussion, because I remember once we had written a case report on a particular side effect, a very rare side effect the drug caused in a patient who was manic. And in him, the getting consent was not a problem because he was manic. So he said, you write about me, you publish it anywhere, it's going to help the world, that is fine. So that was not what we call an informed consent. So we had to wait till his mania settled, and to protect him, we made sure that we talked to his father also, that the father had no objection to that. And when we wrote the abstract, we showed it to him, got his signature. We didn't show him the discussion because we thought the discussion was not relevant to him, and we felt that that had a lot of theoretical issues which actually might worry him because of the drugs he was on. So that is what is recommended in terms of confidentiality in writing and speaking. And speaking in things like, for example, if you're doing a lecture or if I'm giving you an anecdote about a patient, what is always, again, this is common sense, that we don't use personal details which makes the person identifiable. If we do happen to have some VVIP patient, that we don't discuss that person, so that because that makes it very easy for confidentiality to be broken. Another practical area is with medical education, where all of us have to balance the need for educating students, for making sure they get the information about patients, but on the other hand, balancing patient rights. So a simple thing we all do, and I'm sure you do, is asking the patient for their consent. And in my experience, I find 99% of patients are absolutely thrilled to talk to medical students and to discuss about their problems, and they're happy that others are going to learn from them. But a few patients who say no, we have to respect that. A huge practical problem now in clinical practice is information to third parties. Now, there again, you have to go case by case. And another practical problem, for example, in St. John's is patients whose bills are paid by the company. So what information can be divulged? So what is recommended is that we have to follow the rules, in the sense that if the company is paying the bills and their requirement is a discharge summary, we give a discharge summary which gives the diagnosis, but we don't write all the details which can have like personal details or which are not relevant. And again, with insurance agencies, what I always tell patients is that I cannot lie. I have to write that suppose somebody has a psychiatric illness for the last 20 years. I cannot write that it's only 3 months because I can get hauled up. But in fact, for admission, my policy is to tell people who come with pure psychiatric problems and who ask about insurance, we say that please check with the insurance company whether they'll reimburse you or not. And I don't know whether you've had the experience with car claims and this and that. What the insurance agency promises you when you're writing up, you're applying is totally different when you're trying to get a claim from them. So I warn the patients that you're unlikely to get a claim. You try by all means, but this is what I have to say, and we have to work with that. Now, if confidentiality is going to be breached for whatever reason, that you feel that the situation is going to be unsafe, then there are certain ways of going about it. And again, dealing with young people in St. John's in an outpatient clinic, one practical problem we face with young people is that when we ask them what happened, they say that I'll tell you, but promise not to tell my parents. What I tell them is that I can't blindly promise you confidentiality, but you can be rest assured that if ever I break it, I will discuss it with you first. And I'm not going to tell your parents right now what it is that made you attempt suicide. But if there are some situations where the parents don't even know the young person has attempted suicide, and then I say that, I'm sorry, that is something